All right, so we're going to continue on with our talk of cardiology. So this will be the last section for Pharm 1, so 2/3 of the way there. Good job. This will cover the last two sections of cardio, and then I'm going to upload one for like hematology stuff. That'll include a lot of our anticoagulants and things like that. And then the last section will be the oncology section. It's my least favorite group of drugs, so that'll be the most fun for us to talk about ad nauseum. You'll get that joke later when you realize that chemotherapy causes you to vomit a lot. So, okay, so let's talk about angina. What is angina? Chest pain, right? Why do we get chest pain? Ischemia, right? Because we're not delivering to the heart. So essentially what we're seeing, and a few definitions here. We have our ischemic, and you guys talked about this already, correct? All right, fantastic. So this will be a minor amount of review, and then we'll talk about some of the pharmacologic therapy we use for angina, because again, it's going to be pretty heavy for the pharma stuff. So again, ischemic heart disease, basically we're having this imbalance between either not delivering enough oxygen to the heart, or the heart is demanding too much oxygen. So because we have that imbalance, that leads to myocardial ischemia, which leads to pain, and thus we have this issue here of ischemic heart disease. I forgot to plug in my mouse, but that's okay. So anyway, so we will see that with coronary heart disease being defined as having this atherosclerotic narrowing of the coronary arteries, right? So we can kind of divvy that up into several different categories. We'll talk about acute coronary syndromes, right? So we'll talk about acute MI, unstable angina, things like that. And then sudden cardiac death, chronic stable angina. We'll talk about all of these and how we can treat these. You realize that some of these therapies are going to be good for extension of life. Some of these are really good for like mortality benefits, and some of these are going to be more symptomatic only. And so we'll look at those delineations there. And it's important to realize, which ones are going to be good for my patient in the long run from that standpoint, and which ones are just kind of for the kind of short-term symptoms. So anyway. So looking at the kind of two sides of the equation, we have the oxygen availability. This is going to be dictated by things like the coronary flow and distribution. You're going to see that this is going to be one of the primary problems with a lot of our patients, having that kind of narrowing of the coronary vessels. We'll look at see our actual arterial PO2 concentration of oxygen can also be affecting that. So obviously if you're depleted of oxygen, that can also lead to ischemia. And then the ability for the vessels or the myocardium itself to actually extract that oxygen, which usually isn't too big of an issue. Then as far as the requirements go, obviously it's going to be dictated by things like the heart rate, wall tension, and contractile state. So that's why, again, when do you normally have patients experience anginal symptoms? During exertion, right? So again, they're increasing oxygen demand. They're not able to deliver from the supply standpoint, so then they develop that angina, right? As I mentioned, heart rate's really important here. Contractility. So we've already seen several drugs that can affect heart rate and contractility. Do you remember any could affect that? Beta blockers are a huge one. What's the other big group? Non-dihydropyridine calcium channel blockers, right? So the dihydropyridines would not really affect that so much because they're mainly affecting the vasculature. So also see that the wall tension here can be affecting the myocardial oxygen demand. This can be affected by things like ventricular volume and pressure. So think about things like the preload coming back into the heart can affecting that. Afterload is going to be important here as well, that kind of pressure that we're actually pumping against. So you're going to find that some drugs are going to be affecting the preload, or allow for either more venous storage of blood, or you may actually see that we may try to do things like get rid of plasma volume. So, any drugs that can do that? Diuretics, yeah, absolutely. So that's the best way to get rid of fluids is just pee it right out. The afterload is going to be important because if we're looking at that pressure that the heart's having to pump against over time, just like any muscle that gets overworked, it gets hypertrophied, which can lead to those kind of issues we see there. So we'll find drugs that are going to be really effective at treating the afterload aspect of that, and we've already talked about a ton of those. What are some examples of the drugs that can affect our afterload? So yeah, calcium channel blockers, both non-dihydro and dihydropyridines can do that. What else? I just had a whole test on hypertension, right? ARBs, ACE inhibitors, beta blocker, diuretics can even do this to some degree. Like, we use hydrochlorothiazide for hypertension as one of our kind of mainstays of therapy there. So again, a lot of drugs can affect the afterload by affecting the amount of pressure the heart's pumping against. So, and again, if you're looking at, I'm sure you've seen pictures similar to this before, looking at this kind of atherosclerotic narrowing. Some of our therapies are going to be really important for helping to kind of prevent this progression here to getting more and more of an occluded vessel. Do you know anything that can kind of help prevent this from occurring? Yeah, think about like your statins, right? These are really important for helping to prevent that progression by getting your cholesterol down, by getting that kind of in check and preventing a lot, because there's a lot of inflammation going on here as well, right? A lot of the kind of pleiotropic effects of statins come about from doing things like decreasing inflammation, decreasing platelet aggregation, and that's really kind of the big issues we're going to run into here. And we'll see this more when we talk about AMI and getting into the actual myocardial ischemia when it actually is a full blockage. We'll talk about that in a little bit. But again, we're trying to progress or prevent this from progressing as best we can. So this is again why early therapy is going to be best, because are you having anginal symptoms here? Probably not. Are you having them here? Probably not. It's not until it's really all the damage is done and when you get to the big issues there, right? So it's really kind of very much progress until you really start to see those symptoms. Try to prevent it if we can. So again, this is going to be this kind of latent manifestation of ischemia, this angina here. It can occur with any degree of stenosis, and we'll find that some people have this just due to kind of vasospasm, right? So you'll hear about this Prinz-Metal angina. Have you guys talked about that before? Right, so that's not necessarily due to occlusion of the vessels due to atherosclerosis. It can just be due to the actual vasospasm itself. So we'll look at the therapy for that. It'll be a little different. We'll talk about that later. But we can see, when you about 50% of the left main artery, which what's another name for the left main artery? Coronary, the widowmaker, right? So that's the one a lot of people die from that by blockage of that. And then 75% of other vessels. So again, you have to have pretty decent occlusion before you actually have these kind of symptoms upon exertion. In greater than 90% stenosis, almost no flows going through here. That's when you really run into some big issues. So I mentioned that Prinz-Metal angina. This is going to be also called a vasospastic or variant angina. This is a lot of times due to things like autonomic control. So we can try to do things like try to prevent that vasospasm by using drugs that maybe prevent that smooth muscle constriction. Any drugs that can do that? Nitroglycerin is going to be good for helping to relax that muscle. What could happen, potentially prevent it from squeezing down in the first place? Possibly an adrenergic antagonist might be one option. Also think about things that are directly relaxing that smooth muscle. Think about calcium channel blockers, right? Dihydropyridine specifically. We'll see those are going to be really important for treating Prinz-Metal angina is actually one of the first line drugs for that, as we'll see a little bit later on. But again, it can happen to different people at different times. It just depends if they happen to have that kind of predilection towards having that vasospastic quality. But we'll talk about that a little bit later on. Anyway, risk factors. Obviously here there are going to be non-modifiable and modifiable risk factors, so obviously we want to focus on the modifiable ones if we can to try to prevent that progression of disease, because obviously angina is this kind of on that spectrum when you're kind of on your way to having an MI. So again, it's kind of our first kind of warning signs that hey, we need to do something now in order to prevent this from occurring. Obviously we can't change the age of the patient. We cannot change if they have a family history or if they have any kind of genetic predilections for having acute coronary syndromes or having cardiac disease, but we can do things like affecting their diabetes. We can try to get them to be less sedentary, affect their tobacco consumption, all these kind of things that you guys will cover much more in other classes. But obviously these are the things you want to focus on from a non-pharmacologic standpoint, because they're going to have kind of the best return on your investment, best bang for your buck as far as these interventions go. So our treatment goals, we want to increase quantity of life. We'd like to prevent our patients from dying whenever possible. Unless you really don't like them, then just kidding. Don't want to do that. Well, again, the goal here is to prevent that ACS, that acute coronary syndrome, and then increase that quality of life. This is the other big thing. So you want to try to either prevent symptoms from occurring, or if they're happening, you want to go ahead and try to relieve those symptoms as quickly as you can. So we'll see there's drugs that can do both. Some that will work on one or the other, and so we'll see what those kind of breakdowns are going to be. And that'll be important if the question comes up on a test, like, hey, patient is experiencing these symptoms, what are you going to do for them? It's important to know, hey, am I just treating symptoms, or am I trying to extend life here? We'll look at that. Okay, so things we can do, some of our treatment strategies. Again, we're going to focus on both supply and demand. So if we can decrease myocardial O2 demand, that's going to help us to prevent that actual ischemia from happening in the first place. So we can decrease heart rate, we can decrease contractility, and if we can decrease that wall tension. So this will be things that are more focusing on decreasing preload and afterload. Okay, so those are three things we can do to try to decrease the amount of oxygen the heart is requiring on a constant basis. The other thing we can do is increase that O2 supply, so we try to improve flow through those vessels. We can also looking for some of the other things, include like stabilizing those plaques to prevent an acute coronary syndrome from happening in the first place. That's where a lot of things like statins are coming into play and whatnot. And then again, modifying these reversible risk factors or modifiable risk factors. All right. So obviously, kind of the best thing you could do for the patient is actually do revascularization, right? So again, a lot of times, especially when you talk about, have you talked about like treatment of acute MI? Yeah, so you talked about it a little bit. So basically, you know, the primary thing we do now for patients is what? Yeah, send them for cath, right? Send them to the cath lab. Back before we had cath labs available, we used to do things like clot busters and things like that. We'll talk about this fibrinolytics a little bit later, but those aren't really our goals, our main stage of therapy anymore. If you can just open up the vessel again by doing revascularization, by doing things like cabbage, you know, getting a bypass, that can be pretty useful, right? But hopefully, you know, we're going to go with the less kind of intensive kind of treatments here, unless I'm trying to think. Less invasive, I should say. We can do that with drugs, right? So we're going to have things that are anti-anginals, right? So there will be things that will prevent symptoms from occurring or treat symptoms that are already happening. So this will include things like our beta blockers, calcium channel blockers, and nitrates. And then we'll look at some drugs that are going to be more vascular protective. So these include things like antiplatelet drugs. You think of anything off the top of your head that would fit that bill? Aspirin's are going to be our mainstay there. We'll talk about statins and also ACE inhibitors, right? So these are vascular protective. These help to not necessarily reverse, you know, the atherosclerosis, but they can help to prevent it from getting worse. And then obviously looking at the lifestyle changes. So as far as our pharmacology overview goes, we're going to decrease heart rate, contractility, and that systolic wall tension. So we're going to be focusing mainly on calcium channel blockers, nitrates, and beta blockers from this standpoint. And as I mentioned, that blood flow. We'll also see that calcium channel blockers can be useful for an increasing coronary blood flow by helping to relax those blood vessels. Nitrates are going to be good. What do nitrates do? Yeah, vasodilation. We'll see that's going to be really important there. Aspirin, which will be an antiplatelet drug. And you guys heard of clopidogrel before? Yeah, this is going to be another kind of antiplatelet drug we'll talk about more in detail. I'm not sure if we don't cover it here, we'll cover it definitely in the anticoagulant kind of section when we talk about in the heme section. So anti-anginals, the primary thing these are going to be helpful for is helping to improve exercise capacity. So for instance, you know, how long does it take for a patient to develop these symptoms? You know, if for some patients who have, you know, pretty advanced angina, walking over to that door might be enough to start to have exertional symptoms for them, right? They start to experience that chest pain. If I can get them walking to the elevator, that's an improvement, right? And that's what, you know, kind of the measures, some of the measures you're going to be looking at for kind of efficacy of these drugs. We also want to look for reducing kind of exercise-induced ST changes during, again, signs of ischemia. And then we want to decrease our frequency of symptoms. So some of these drugs are going to be more kind of prophylactic. We're going to be taking it every single day in order to help prevent symptoms from happening in the first place. So doing things like beta blockers, calcium channel blockers, and nitrates. And we'll look at where each of these are going to be important in use, because a lot of times you're deciding on which ones to use based on other comorbidities, other issues that are going on with the patient. So again, drug selection is really important here to decide, like, okay, which drug is going to be best for my patient, because in some cases beta blockers are a really good option. Other patients, a calcium channel blockers are going to be a better option, and your job is to figure out which one's which. So obviously you can classify angina based on you know, limitations on physical activity, on you know, findings at rest, you know, how symptomatic are they really. I'm not going to get more into detail on this because you guys will cover that in other classes, but just know that we are kind of focusing on symptomatology. You're looking for changes, looking kind of pre and post to see how effective your therapy is actually being. And so again, good patient education, making sure they're taking diaries and things like that, so you can see just how effective your drugs are going to be. All right, so getting into specifically the different pharmacology categories, we're going to look at several different classes of drugs we've kind of alluded to already. We're going to see what effects they're going to have, not only on the demand of oxygen by the heart, we're also going to be looking at the supply side as well. So we'll see where some of these drugs are pulling double duty. Some of them are only going to be mainly focusing on one or the other, right? So as far as beta blockers go, this is going to be focusing mainly on decreasing heart rate. How does it do that? Beta, which receptors? All right, beta 1 receptors, right? So that's directly affecting automaticity of the heart. So we can slow that down. It's going to be good. Helps to decrease contractility. It will help to lower the systolic wall tension, because it's going to be able to help decrease that systolic blood pressure, right? So again, that's a direct sign of that afterload. Why do you think this will have an effect on left ventricular volume? I should increase that. What do you think that would be? Yeah, so it could have to do with one of the things you'll find is that sometimes filling volume can be an issue for some of these patients. So if you can slow down the heart, you can actually end up having a longer time for the ventricles to fill up. So in one case, that could actually increase the amount of blood volume the heart's having to pump. It can be a beneficial thing if patients already had really kind of stiff ventricles that didn't like to fill very well. So this can be very useful to give it just more time for it to fill in those cases. So again, not going to be super effective at decreasing cardiac oxygen demand from the preload side, but it can certainly affect the afterload side by decreasing that total peripheral resistance. So that's going to be good for us, right? Again, no direct effect on oxygen supply necessarily. Will not necessarily help to dilate those coronary vessels or anything like that. We'll see the other drugs will affect that more likely. So in the absence of other indications or contraindications, these are going to be first-line drugs that we're going to use for our patients as an anti-anginal drug. This is going to be very useful for patients who have, exercise-limited capacity due to, angina. If they also have things like hypertension, supraventricular arrhythmias. We'll talk more about antiarrhythmics later on. They have heart failure. Again, we were going to see when we talk about heart failure specifically, there's certain beta blockers that they need to be on because it helps to improve mortality. And then also post-MI, we'll also see that these are going to be some of the kind of required list of drugs patients need to be on after an MI. So again, in one of the things we run into, giving a beta blocker to like a relatively healthy patient, what does that do to their exercise capacity? Usually decreases, right? So again, if you try to take a beta blocker and go run a mile, you're going to be feeling pretty crummy because your heart's not going to be able to kind of respond to that increased output by your sympathetic nervous system. For these patients, though, because that oxygen demand side of things is going to be much more important for their exercise capacity, this improves it pretty greatly for those patients, right? And so as far as our drug selection goes, we're going to see that beta-1 selective or non-selective beta blockers are going to be fine for they're going to be able to treat the anginal symptoms equally well, right? Now, obviously, this is not the full list of beta blockers. These are just, again, some examples. But beta-1 selective, who's that going to be good for? Yeah, asthmatic patients is probably going to be better for them. Also, if you think about beta-2 receptors, what do they do to the vasculature? They usually vasodilate, right? Always think of beta-2 receptors as being more smooth muscle relaxing, and so there is some theoretical benefit to using a beta-1 selective drug where you can actually end up having some improved relaxation of the vascular smooth muscle. Clinically, it probably doesn't really matter so much. A lot of times you're going to see that third generation drugs get used as well. Carvedilol is going to be another important one when we talk about CHF. Again, that one's nice because it has some additional properties, not just beta blocking ability, but also things like alpha-1 antagonism, things like that, which we know if we block alpha-1 receptors, what does that do to the blood pressure? It should decrease it, right? Because alpha-1 is vasoconstrictive. So if it can block that, that's going to be beneficial as well to help reducing that afterload. So obviously contraindications, important that if your patient already has kind of a resting low heart rate, you probably don't want to make them more bradycardic because that would be one of the primary things you're going to cause by blocking those beta receptors. Already hypotensive, have an AV block, or acute decompensated heart failure. This is one of the things you have to be really careful with heart failure patients because, again, their primary issue is they have poor ejection fraction, they have poor left ventricular dysfunction, or poor left ventricular function, I should say. And so if you put a beta blocker or a direct cardiodepressant on them, you can exacerbate their CHF. This is why when we talk about that, you have to go very, very low dose, titrate it very, very gently. Otherwise, you can lead them to be in the hospital, essentially. Obviously, watch out for if they have reactive airway disease. So again, if they have asthma and you're using a non-selective beta blocker, there is a possibility there you can cause some issues with their asthma. We saw that how this can worsen diabetes or potentially, eliminate signs of hypoglycemia. And then also patients with peripheral vascular disease, you actually worsen that with beta blockers. So again, know who's going to be a good candidate for these drugs, know who's going to be a bad candidate as well. Obviously, our adverse reactions go right along with the physiology or the pharmacodynamics of these drugs. So hypotension, bradycardia, hyperglycemia, we've kind of all talked about these already. Obviously, again, sexual dysfunction can be a really important thing for your patients. And of course, you have to look at, okay, well, what was limiting your sexual function before? Was it the anginal symptoms or, what was it? But again, look at the, all sides of things to make sure that your patients are going to be best treated based on their symptomatology. Obviously, monitoring, looking at heart rate, blood sugar, all those things are going to be kind of standard monitoring parameters. And then, again, avoid rapid discontinuation. Why do I say that? Yeah, that kind of rebound hypertension, rebound tachycardia. I want to watch out for that. So be careful. And then also dizziness, fatigue. Obviously, patients who are more elderly, they have poor hemodynamic function. Orthostatic hypotension can be a really big thing, which can lead to what? Yeah, syncope, dizziness, falls, fractures, all kind of bad stuff down the road. Okay. So then next we're going to look at our calcium channel blockers. And again, notice when I talked about hypertension, how I said a lot of these drugs are pulling double duty for other disease states. So again, we're not going to have to belabor all these points. Stuff that came up in the hypertension section about these individual drug classes are certainly game here as well, right? As far as the adverse reactions, drug interactions, all that good stuff. But here we're going to talk about the dihydropyridines and then the non-dihydropyridines. So again, we're going to find that if anything, the non-dihydropyridines are going to be better on the demand side of things because they're going to help to decrease heart rate, to decrease contractility. They're going to help with both the systolic blood pressure and then either probably have kind of a neutral effect on the preload side of things on LV volume. If anything, you might see that it'll go down a little bit. These because it causes vascular smooth muscle relaxation. You're going to find that the veins tend to hold on to a little bit more volume, so you may actually see kind of neutral effects on the blood volume as far as what's getting back to the heart. Notice though that with the dihydropyridines, what are they going to do to heart rate? It's going to go up, and why is that? Yes, the heart compensating for that vasorelaxation, right? That TPR is going down, so the heart has to respond by increasing cardiac output, which is often by increasing heart rate. So again, you might be thinking like, well, how's the dihydropyridine going to be a good option for these patients if it can be potentially increasing that oxygen demand by increasing heart rate? Okay, that seems a little odd, but we're going to see it has good effects on decreasing systolic blood pressure. Probably not going to really do a whole lot to contractility. It's probably mostly going to be kind of neutral on those degrees. And again, you don't have to know how many arrows are going to go with each of these, but think about the pharmacology of the drugs. Think about how they're going to be affecting the heart, the vasculature, and all that good stuff. Now, you may find on the supply side this can actually help with relief of vasospasm. So we'll see that dihydropyridines are going to be good options for that princemetal angina, as we'll talk about in a second. You may also see a little bit of mild dilation in areas of this kind of fixed stenosis. So you can have a little bit of increased supply of oxygenated blood to the heart, but again, it's not going to be the primary reason why these drugs are useful for angina. And again, breaking these down into their individual categories of being non-dihydropyridines versus dihydropyridines. Just note that most of these are going to be acting very similar as far as their classification goes. So again, the non-DHPs are going to have very similar activities to one another. So again, diltiazem, verapamil, oftentimes it can be interchangeable. And then looking at your dihydropyridine, these are just 3 examples, probably the more common ones. Amlodipine is probably the most common one you're going to run into. You guys remember the brand name for that one? Yeah, Norvasc are probably part of the most common calcium dihydropyridine you run into for a lot of patients to be on. With my phone. Okay, so they're placed in therapy, so you can find that this is going to be good for kind of reduction of symptoms if you cannot use a beta blocker or they're not tolerated for any reason, right? So patients just not really doing very well with the beta blocker, you can utilize a non-dihydropyridine as an option for that, right? You can't replace a beta blocker with a dihydropyridine because that doesn't really make sense from a pharmacology standpoint, but certainly non-DHP can be fit in for a beta blocker if they can't tolerate that. Does that make sense from a pharmacology standpoint, right? Because they're both going to be depressing cardiac function. They're both going to be decreasing automaticity and contractility. In that regard, they have very similar activities. So non-dihydropyridines and beta blockers think very similar together. Sometimes you can utilize, if you already have a beta blocker on board, right? So you're already affecting kind of the oxygen demand side of things by affecting the heart. And it's not successful by itself, you may add on something else, right? So you can add on a dihydropyridine in these cases. So why wouldn't I want to add on a non-dihydropyridine to a beta blocker? Yeah, too much depression on the heart, right? So you don't want, you just basically be causing increased risk for bradycardia, AV block, things like that. So you don't want to cause that. So again, beta blockers and non-dihydropyridines, you don't want to mix together. I can't think of a clinical situation where that's a good idea. But certainly a dihydropyridine plus a beta blocker, okay to go, right? As long as you're monitoring blood pressure and as long as you're monitoring these symptoms, you're good to go. And then occasionally you may utilize the calcium channel blocker plus a nitroglycerin kind of based product or a nitrate based product. So that can be a useful adjunctive agent as well. Okay. So again, think about who would be a good candidate for these drugs. Think about patients who have contraindication or intolerance to beta blockers. We'll talk about that vasospastic angina. They have severe peripheral vascular disease, can help with those patients. Uncontrolled diabetes, you find that typically calcium channel blockers don't really have as negative an effect on diabetes as beta blockers do. And then again, for LV dysfunction, in those cases, they had poor LV function, you would not want to give them a non-dihydropyridine because we already saw it's cardiodepressive, but a DHP might be okay for them in those cases. Okay. So again, as far as drug selection goes, in non-dihydropyridine for initial therapy, a dihydropyridine if you're going to add it on to a beta blocker, and then typically we avoid short-acting agents. So again, a lot of them either have a long half-life or have an extended release product. Things like nifedipine, they're short-acting, they can actually cause pretty big drops in your blood pressure, which is not going to be beneficial for your patient. Okay, So contraindications are going to be pretty similar to what we see with the beta blockers. Again, avoid if they're already hypotensive or if they're already bradycardic. Again, that's more going to be focused on the non-dihydropyridines because, again, that can cause bradycardia. They have acute heart failure. Typically for heart failure, we're going to avoid our non-dihydropyridines, mainly just due to that cardiodepressive effect. In some rare cases, beta blockers are okay for those patients. We'll talk about the 3 that have indications for that. But non-dihydropyridines are pretty much a no-go for CHF. And they have a poor ejection fraction. This again goes with similarly with that acute heart failure. AV block as well, obviously. And then as far as precautions go, watch out for the CYP3A4 interactions. Do you guys remember which calcium channel blockers affect that? The non-dihydropyridines, right? So think rapamycin. Again, if you imagine, these patients are probably on a lot of other drugs that are CYP3A4 mediated. Think if they're on simvastatin, right? If they're on Zocor with hyperlipidemia, they might also end up needing to utilize one of these drugs. Watch for those CYP3A4 interactions. Okay, obviously adverse reactions include hypotension. Due to the dihydropyridines causing more of that kind of the vasorelaxant kind of effect, that's kind of their predominant feature. See a lot more headache, flushing, peripheral edema as being a possible side effect there. Again, watch for release of symptoms. Obviously, you're going to have your patient kind of, hopefully take tabs on, when they're having symptoms, if they're improving at all or getting worse, and monitor for that heart rate. And obviously, constipation can be a big thing for a lot of elderly patients. Imagine what other drug class is kind of notorious for causing a lot of constipation? We haven't talked about it here yet. Painkillers, yeah, opioids are another big one. So again, think about it for patients that has chronic pain issues, right? Maybe the reason why they're really sedentary is because they have really, bad osteoarthritis and they can't really get around. They're on painkillers. Think about these things, how they can kind of lead into kind of worsening side effects for them. And then we're going to look at our nitrates. These are going to be good for not necessarily on the demand side. It really doesn't have a good effect at decreasing oxygen demand in the heart. If anything, you notice heart rate goes up. Because what do nitrates do? We've already said it kind of. Vasodilation is a really big thing. So we're going to see that it doesn't really help on the heart rate side. You certainly will see blood pressure go down with this. And if anything, you may see left ventricular volume go down as well, mainly due to the kind of this venous dilation that you can see there. Again, usually the veins are pretty good at storing a lot of plasma volume, a lot of blood, but this can help to relax them a little bit even further. So again, you typically see left ventricular volume go down with these drugs. As far as from the supply side, this is where they get most of their therapeutic benefit, and this is going to be useful for helping to dilate coronary arteries. And why is that important? Yeah, you're opening up that blood flow, you're getting more oxygen to the heart, you're directly affecting what's causing that ischemia in the first place, and that angina. It can help with that relief of vasospasm, and then also we'll have some antithrombotic and antiplatelet effects. It's more of a kind of a minor issue here. That's going to be important for when you get those kind of plaques that are generating, when you have an acute thrombosis that is occurring, and this can have some beneficial effects there. So the way that these drugs are going to work, so nitrates, otherwise NO, is going to be basically having some positive effects here. You're going to be increasing generation of cyclic GMP. Okay, so increased cyclic GMP. This helps to activate protein kinase G. Remember, this is that kind of secondary messenger pathway we've talked about in pharmacodynamics before. This will help to lower cytosolic calcium concentrations. By lowering that, you're going to have more smooth muscle relaxation, at least the vasodilation, and thus decreased blood pressure. That is the primary method by which these are working. So we're donating nitric oxide to these blood vessels that directly decrease the amount of calcium getting into the cells, unless you have relaxation of the vessels. Okay. And you notice here, anyone know what PDE stands for? Kind of alluded to it previously. Phosphodiesterase. This is really important because if we're blocking, or phosphodiesterase is normally useful for helping to metabolize cyclic GMP. So if I were to have something that were, say, to inhibit this, you would end up getting kind of some synergistic effects here. You have way too much cyclic GMP, you get way too much vasodilation, you see pretty profound hypotension. So does anyone know what you use these drugs for? For erectile dysfunction. So this is like your Viagra, this is your Cialis, this is your Levitra. So again, the drugs we use, and one of the big things you'll see if you ever watch any of these Viagra commercials, that make sure don't take it with a nitrate. And I can see why that's a really important thing, because if I have a drug that is inhibiting this enzyme, I have way too much, and when we get to the urology section, we'll talk about erectile dysfunction and why these drugs work. But essentially, you see some pretty big synergism here where by inhibiting this enzyme, you have way too much cyclic GMP. Nitrates are going to further synergize with that, and you have way too much hypotension that can develop, something very, very profoundly hypotensive, right? This is why it's very important to make sure you're kind of educating patients who have concomitant erectile dysfunction along with angina. This can be a pretty dangerous combination. of priorities in life. So again, die of a heart attack, get to have sex, you know, priorities. All right, so the drugs we're going to use here, short-acting nitrates. The main goal here, and when do we use short-acting nitrates? Yeah, during an acute chest pain, during acute MI, all these cases. So again, you're having chest pain. These are going to be quick relief drugs, right? This is going to be the things you're going to educate patients. Hey, as soon as you have onset of chest pain, take one of these, call 911. We used to do it to where we would actually, basically, you know, if you get relief out of the first dose, 5 minutes or so, then you're generally pretty good to go. We used to say, hey, do 3 doses. You know, wait 15 minutes and then call 911 if you're still having chest pain. We've kind of gotten away from that a little bit because people were waiting too long. And again, one of the big things you'll notice with MI, similar to stroke, is that time is muscle, time is tissue. So you want to try to get those patients in soon in order to help preserve as much of that tissue as you can. These drugs are good for helping to relieve acute symptoms of myocardial ischemia. They help to prevent this effort-induced angina, right? So they can help with the kind of exercise tolerance. And the main drugs you're going to use here include things like nitroglycerin, sublingual spray. So they can actually, you'll find that oral administration of nitroglycerin is no good. The GI tract just tears it up. So what we can do is actually have oral absorption, you know, through the kind of buccal surfaces by using sublingual nitroglycerin, which is a spray, as I mentioned, or we can use something like a nitrostat, which is very tiny tablets. You basically have the patient put underneath their tongue and allow it to dissolve and kind of absorb on its own. Okay. So those are kind of the main things we're going to use. Again, dosed every 5 minutes until either you have relief or EMS arrives, in which case they may end up giving you more nitroglycerin either through an IV or PO. And then again, if they, you know, good education point, no relief within 5 minutes, go ahead and call 911. All right. Now, when you have these kind of short-acting vasodilators, this is similar why you don't like to have short-acting calcium channel blockers on board. You can see pretty big drops in your blood pressure. This can worsen orthostatic hypotension to a big degree. So make sure that when patients are kind of getting up, moving from sitting to standing, that orthostatic hypotension can be pretty profound. So you don't really, you know, just sit down, chill out. You know, it's going to help with the exercise-induced angina anyway. And then looking at, as far as storage goes, nitroglycerin is not a very particularly stable stable substance, right? If you get 3 nitroglycerins together, what happens? We get TNT, right? So trinitroglycerin, essentially. But so anyway, so it's not a very stable substance, and so we want to make sure we're keeping these in the original packaging, cool and dry place. So I've seen patients who will have a thing of nitro, their tablets, and they will keep it, put it into a different pill bottle. Light is a very important thing. You'll notice those come in amber vials. If you look at that previous slide, light can affect this, so that's why you want to make sure you keep it in a nice amber vial that helps prevent UV rays from helping to destroy the drug. And then they'll keep it around for years and years and years, because again, typically old people, they don't like to get rid of stuff, they like to hold on to their drugs, and so you'll find that nitroglycerin can break down over time. And so, you know, even if they've only used 1 tablet out of it in that 3 to 6 months, we recommend they throw it away and go ahead and get a refill. Again, that's not the drug companies necessarily trying to get you to re-up on your prescription, right? You know, big pharma out there is usually pretty evil, but this is not one of those cases. There's actually a really cool study. They were looking at drugs. I guess there's like a pharmacy that was like really old from like the 30s or something. They found a bunch of drugs like in a cabinet stored somewhere, and they were looking at these drugs, and they did a bunch of GC mass spec to figure out if the drugs were still in a similar concentration to what they were originally marketed as, and almost all of them were exactly the same, right? So drug stability is typically pretty good. Aspirin is one that breaks down very easily, but nitroglycerin is another big one. So again, recommend replacing it after 3 to 6 months or so, once it's been opened. And again, you apply it directly under the tongue, either spray or the tablet, whatever happens, but you don't tell them to swallow it, because then it's not going to be as effective. All right, and then on the flip side of that, we have our long-acting nitrates as well, and so these are going to be more useful for helping to prevent symptoms. These are going to be long-acting drugs you're going to take every day. They're going to help to you know, especially if you can time these things around to when the patient's more active, you're going to find the best benefit. So again, when are patients usually most active during the day? Or I guess not during the day, but during a 24-hour cycle, when are they most active? Daytime, right? So morning time, daytime. So again, you typically want to dose these drugs, you know, around when they're getting up, so that way they're kind of going to be most useful during that time period. We'll talk about nitrates and tachyphylaxis in just a second here. So where are these going to be useful? They can help to reduce symptoms. They can help to prevent symptoms from recurring. Typically, you don't use a long-acting nitrate by itself. Typically, you're going to use it as an adjunctive agent on top of a beta blocker or a calcium channel blocker. Or if they're absolutely contraindicated from receiving either 2 of those, then you potentially could use this by itself. But typically in combinations where you're going to get the most bang for your buck out of these long-acting nitrates, not recommended really as monotherapy. So a couple of different options you have here for long-acting agents. We have this isosorbide mononitrate, otherwise known as IMDUR. This one is 12 hours lasting and be dosed daily. We also have isosorbide dinitrate. This one has a little bit shorter duration of action. It's dosed about 3 times daily. So usually you see a lot of people using the IMDUR just because it's going to be a once daily drug. Now it lasts only 12 hours. Why do you think it's important that it doesn't last 24 hours? I mentioned a term just a second ago. Tachyphylaxis, right? So again, going back to pharmacodynamics, if you guys remember that example we had, this is the prime example of tachyphylaxis. Nitrates, if you apply them 24 hours a day, they lose efficacy, right? They end up running out of those kind of cofactors and different things like that they need to make the pathway work. And so when you say the patient has tachyphylaxis, what does that really mean? Yeah, and resistance probably isn't even like the most accurate. It's more like, you know, it doesn't matter how much you increase the dose. I can't overcome that resistance. Like there's no way to get any more drug effect. The only thing I can do is to remove it completely, allow the body kind of start to replenish, and then you can give the drug again, right? Because you usually think about things like resistance to like opioids or resistance to antibiotics. In a lot of cases, you can increase the dose to get over that hump. In this case, it doesn't matter how much you increase the dose, not going to change anything. So we also have some topical products we can give as well. So this is again nitrobid, which is going to be a nitroglycerin ointment. I'm sure people who worked in the ER have seen people have this applied before. You actually can apply it on this nice little kind of wax paper card. The dosing is usually either in inches or centimeters, and then you basically just slap that on the patient, usually on their chest. I don't know if this is necessarily any more effective on the chest than anywhere else, but you slap it on there, and then they can have some relief of their chest pain. So again, this is a 12 hours on, 12 hours off kind of product because of that tachyphylaxis. So again, you put it on for 12, remove it, kind of wipe off the skin, make sure it's nice and clean, and then you can apply it again in another 12 hours. Okay, it's really important that you do it on that calibrated paper, so that way you just kind of slap it on the patient, you leave that paper there, so that way you don't have ointment kind of going everywhere or getting on their clothes or anything like that. It's just going to stay right on the skin. You can always wipe off the previous dose. We also have patches that are available as well that, again, are going to be 12 on, 12 off sort of thing. Typically, you think like transdermal patches, like you think, I can put it on a day at a time or 3 days and things like that. This one, again, is going to just be that 12 on, 12 off sort of thing. This is really important, especially for like nursing from their standpoint when they're applying this drug, is that it has, because it has good transdermal absorption for the patient who's having angina, who else can absorb that? The nurses who's actually applying it. So that's really important because they actually need to wear a specific type of gloves. Typical latex, this will actually go through latex. They have to use these acetonitrile gloves, which I think a lot of places are moving more towards using because of the latex allergy being relatively prevalent. And so using a special type of gloves, they can apply this drug without getting any issues. So if you ever have like a nurse who's like giving nitro paste and then they come back, they're like, man, I got this rocking headache. That's usually what it is. They didn't use proper PPE and they end up absorbing some of it. But again, headache probably being one of the more common effects here because, again, increased blood flow to the head usually leads to headaches, flushing, postural hypotension, all that sort of thing. So again, I mentioned that tachyphylaxis. We don't know the full mechanism. We just know that it happens. And again, you need to have that nitrate-free interval. That's really the important thing. Let your patients know, hey, this is why we're doing it 12 hours on, 12 hours off, and because, again, the drug becomes less effective. And usually that nitrate-free interval should be when the patient has the lowest symptom frequency. Typically that's nighttime when they're sleeping and they're not really having any kind of exertion. But if they were, say, a nighttime worker, they had, they worked the overnight shift, and that might skew you when you wanted to go ahead and dose that drug, right? So kind of take the patient factors into consideration. Okay, contraindications, you want to be careful with things like aortic valve stenosis because, again, you can cause big decreases in TPR, and if the heart can't really respond due to kind of a blockage in blood flow, that can worsen that kind of oxygen delivery to the tissue. Having obstructive cardiomyopathy could be also contraindicated. And then the big one to worry about is going to be this concurrent use of phosphodiesterase inhibitors. Now, again, you think, what type of patients are going to be on these drugs? Older patients? What gender would you think? Typically men, right? Not always the case, though. Think about patients who have pulmonary hypertension, right? It's becoming a kind of a wider spread sort of thing that we're recognizing and treating. You might have female patients who are on these as well for that purpose. Like I mentioned, I give little girls Viagra on a relatively consistent basis in the cardiac unit because of that pulmonary hypertension they can experience, right? Yes, ma'am.
Sorry, why did you say the nitrate would cause an increase in TPR?
It would decrease it.
Oh, thank you.
Yeah. Sorry, if I misspoke, I should decrease it. So again, you can see a pretty big hypotension when you mix these drugs together, and that can potentially exacerbate things and lead to either MI, because again, you don't have enough pressure to deliver blood flow to the areas where it needs it. So you can see stroke, MI can occur here. So we'll be very, very careful with mixing these. All right, so again, looking at the comorbidity a patient has, and then looking at what is going to be our first line alternative agents, and then what we should avoid. Because again, this is kind of the key points here you want to take away is like who's going to be a good candidate for these drugs, who should not receive these drugs, et cetera. Because you want to make sure your drug selection is appropriate and makes sense for your patient. So think about things like hypertension. Okay, well, hypertension, patient being on a beta blocker, that sounds like a pretty good option. That's pretty straightforward. You could use a non-dihydropyridine. That would again be another good option for those patients, right? Now, getting into things that are more complicated, we'll talk about this a little bit more when we get into unstable angina and MI. But they have a previous myocardial infarction. Beta blockers, we're going to see improved mortality. And so we're going to see the beta blockers are going to be our first line here. Typically, you're going to see, at least in the acute phase, that calcium channel blockers can actually worsen this. They don't have any mortality benefit associated with them, so this would not be a good first line. Now, potentially, if I had a patient who had previous MI, they're on a beta blocker, but they were still having anginal symptoms, could I add on a non-dihydropyridine? Or that doesn't make sense, but could I add on a dihydropyridine? That would make sense, and that would be okay, right? Especially if they're still hypertensive, they have other issues that are going on. As I mentioned, decreased LV function. Watch out for beta blockers. Again, you have to be really, really kind of careful with those patients. We'll talk about why a little bit later on. Amlodipine, again, a dihydropyridine could be a good option for them because, again, that has no direct cardiodepressant effects. Again, avoid other calcium channel blockers, namely your non-dihydropyridines. They have a history of bradycardia or AV block. Something like a dihydropyridine would be good, right? Because if anything, this could actually increase heart rate, and increase inotropy and all of that. So that would be one option. Long-acting nitrate could be good here as well. But again, if they're already bradycardic, avoid non-dihydropyridines and beta blockers. Diabetes, typically you're going to find that beta blockers, as we mentioned, are going to be kind of worsening diabetes. So a non-dihydropyridine could be a good option. As alternatives go, if you can see, this stands for cardioselective beta blocker. So again, which ones are cardioselective? Is beta 1 selective ones, right? So they tend to have a little bit less effect on hyperglycemia than you would see with like your non-selective beta blockers. And then for asthma, obviously, if we can use cardioselective beta blockers or non-dihydropyridine, those are your best bets there. Okay, kind of makes sense. And we'll talk about some of these other disease states and their pharmacotherapy a little bit later, and then when you go back and review this will make a lot more sense as well. So looking at other things that are not going to directly affect the symptomatology of angina, but certainly are going to be useful for helping to prevent things like, further MIs or death, things like that. ACE inhibitors are going to be really important here for patients who have coronary artery disease, especially with diabetes, because we know diabetes has a number of risk factors associated with cardiac heart disease. We know a lot of microvascular injury that's happening here, but this is also going to be useful for patients with poor left ventricular dysfunction, right? Think about patients who we mentioned that cardiac remodeling that occurs after an MI or after if you have CHF. This kind of helps to prevent a lot of that remodeling from occurring there. Okay. So again, does not relieve acute symptoms of angina. No one's going to sit there and chew up their lisinopril to try to fix their angina. But again, this is something they should be on pretty consistently. And again, to help to prevent that progression of disease is the big thing. For patients who have post-MI, LV dysfunction, diabetes, they're probably going to be on these drugs indefinitely. Either an ACE inhibitor or an ARB, again, would be a reasonable supplement for that if they could not tolerate an ACE inhibitor for whatever reason. And then really anyone who has CAD or other vascular disease should probably consider an ACE inhibitor as well, right? All right, so as far as combo therapy goes, again, if the patients are still having persistent anginal symptoms along with with their kind of one drug, you can always add on additional therapy. This is where you can combine a beta blocker and the calcium channel blocker, namely the dihydropyridines, if the patient can tolerate it. Some people have found studies that have shown actual improved exercise tolerance with this one, so that's one option. And then typically if a third agent's needed, if you've added on, they have a beta blocker and a long-acting nitrate, and they're still having symptoms, they probably need to go in for some other kind of evaluation for possible cath or something like that. All right, getting into the antiplatelet drugs. Again, aspirin is going to be recommended for these patients. And why do we do aspirin? Why do we care about antiplatelet drugs? Right, because again, when those plaques rupture, they're going to be attracting your platelets. Are going to be attracting other kind of mediators of the coagulation cascade, and that's what leads to those blockages that occur there. We'll talk more about that in detail later on, but these are going to be useful to help to prevent those acute coronary syndromes. They are going to be recommended for all patients with ischemic heart disease without contraindications, right? So, and typically we don't need to necessarily have big doses of aspirin on board, because remember, how does aspirin affect that cyclooxygenase enzyme? Blocks it. Is it a short-term block or is it a long-term block? Irreversible. All right, so it's going to be irreversible long-term blocker of that. So because of that, it affects the platelet. It's done affecting that platelet for the lifespan of it. So we can get away with using something like 81 milligrams of aspirin. Even though it's a baby dose of aspirin, it is okay to give that to adult patients because as long as they're taking it consistently, you should have the majority of their platelets being affected. The only ones that are not yet affected are the ones that have yet to be generated. So aspirin is going to be a good one. You actually have that 30% reduction in risk for some of the primary events, things like myocardial infarction, death, things like that. So aspirin has a ton of studies behind it, a ton of evidence to support its use. So I definitely would recommend that. Clopidogrel, and again, we'll look at a few other options in this category a little bit later on. Plavix is the brand name for this one. Is going to be equally as efficacious, but is usually going to be more expensive. A little bit higher bleeding risk, things like that. So these will be recommended as an alternative to aspirin if the patient can't tolerate it for whatever reason. So if they have like hypersensitivity or some other reason they couldn't take it. Again, we'll look at these more in detail when we get to the anticoagulant section later on. Okay, so again, unless they have a contraindication, they should be on aspirin, right? Usually 81 milligrams a day. They should be on a beta blocker if they have a prior MI. They should be on an ACE inhibitor, especially if they have any kind of diabetes or LV dysfunction. ACE inhibitor or ARB, because again, those are kind of interchangeable. Some sort of lipid-lowering therapy. So again, based on those guidelines we talked about previously, usually pretty high-intensity statins, especially if they have previous, evidence of cardiovascular disease. And then they should also have a PRN as needed for chest pain prescription for sublingual nitroglycerin. Okay, so again, all of these are going to be scheduled drugs. These are going to be scheduled either daily or whatever it happens to be. But then that sublingual nitroglycerin will be, again, every 5 minutes as needed for chest pain. Call 911 after, for no relief within 5 minutes. Yes, ma'am.
Do you put them on ACE inhibitors only if they've had diabetes or liver, or like it's still just both the therapies?
Those are the primary cases, right? Because we have the most evidence of those being effective at treating or like preventing some of those changes. Like, so, for diabetics, it's nephroprotective, right? For CHF patients, it's going to be helping to prevent some of that cardiac remodeling. If they were hypertensive to begin with and had anginal symptoms, I would probably start with a beta blocker, because again, the ACE inhibitor is not necessarily going to affect their anginal symptoms, but certainly it'll affect their blood pressure. So you have to watch out. You have to make sure that by combining all these different drugs together, that you can see hypotension as a potential side effect. A lot of these patients that are going to be so hypertensive to begin with, they probably need 2 or 3 drugs anyway, and so you're just tailoring it based on their comorbidities and trying to get them into range, right? Okay. Okay, so we mentioned if they have daily or more frequent symptoms, some of the prophylactic therapy we already talked about, things like long-acting nitrates, calcium channel blockers, beta blockers, those are going to be good to help to prevent the symptoms from occurring in the first place by kind of improving the exercise tolerance. For that treatment of that princemetal angina or the variant angina, we'll see the calcium channel blockers and nitrates can both be useful, mainly due to their vasorelaxing effects. You can see there, so it can be very useful to kind of block that vasospasm that's occurring. You can actually should probably avoid beta blockers for those patients because really it's not going to be affecting the supply side of the chain as we saw previously on that slide. We're talking about beta blockers, but it can actually lead to worsened symptoms. So that's why we see like dihydropyridines, nitrates are going to be your best bet for if you have that kind of variant angina. What type of patients do you think about having that variant angina? Yeah, typically younger patients, right? So people that don't have like a history of cardiac disease typically. Okay, so let's do a 10-minute break. We'll come back and then talk about acute coronary syndrome. All right, any questions from the first half? All right, so talking about acute coronary syndrome. So obviously you have a couple different breakdowns of acute coronary syndrome. So we have our ST elevation MI. We're going to have our non-ST elevated acute coronary syndrome, so things like unstable angina and that are non-STEMIs. We're going to see from our standpoint the treatment will differ a little bit, but a lot of the times, again, as we mentioned, the best therapy for these patients is the cath lab. Yeah, absolutely. So again, you'll see that in some cases, pharmacotherapy is still going to be important for that, but we're going to see that our use of fibrinolytics, which are going to be our clot busters, has definitely gone down pretty significantly since then, but still important to talk about in case you ever need to use it. So obviously, what are kind of the differences between these different variants of acute coronary syndromes? How would you describe the unstable angina? Yeah, just chest pain at rest, essentially, right? So again, looking at these different types, obviously like the SE elevation MI, obviously kind of being the more serious varieties of this. Obviously a lot more infarction kind of going on. So if you imagine kind of the coronary vessel right here. So how does how do these blockages actually occur here? So this is going to be important to talk about kind of thrombus formation when we're talking about the drugs that we're going to use to try to prevent this from occurring, right? So imagine you have a blood vessel that has a plaque here. It's kind of built up. Normally you have kind of this nice fibrous cap over it that is kind of helping keep everything right there in place, right? So now is there a lot of kind of urge for platelets to kind of bind onto this or cause any kind of thrombus? If it breaks, right? So at this point, everything's pretty stable for the most part, right? So you may have things like exertional angina, but you really shouldn't be having like this unstable angina. The flow should be good enough for the most part. We're not having any issues here, right? As long as everything kind of stays where it's at. So, if you, for instance, in order to actually cause this thrombus formation to occur, you need some kind of inciting event typically. So either if you were to do, like, say, like a procedural injury where you, like, say, deploy a balloon to kind of break down that clot or the plaque and try to, stretch things out, or if you were to, say, just have a spontaneous rupture here, right, that fibrous cap breaks, and you're going to have kind of leakage of these contents out into the vessel. At this point, now we have a reason to kick off like our coagulation cascade and our kind of inflammation. So typically the first characters to kind of approach this and kind of start responding is going to be our platelets. This is why antiplatelet drugs are going to be really important, but you're going to see adhesion, activation, aggregation of platelets are going to kind of bind on, kind of dogpile onto this kind of ruptured plaque. Then you're going to start to have fibrin being formed here. Fibrin is going to be a really important characteristic of this. Again, fibrin is going to be helping to occlude the vessel even more. You're having more platelets kind of getting stuck in with fibrin. And again, this is kind of a kind of cyclical cascade. We're going to get more and more occlusion occurring here as the clot gets bigger and bigger. And then we have our occlusive thrombus. Notice there's going to be a lot of platelets, a lot of fibrin is going to be located here, which is why when you're looking at drug therapy for this, a lot of antiplatelet drugs and a lot of fibrinolytics are going to be the main things that we can use to help break this down. So how does this occur? We see that thrombin is going to be a pretty essential link here between the tissue injury, the coagulation, and then that platelet response we're going to be seeing there. So for instance, you guys remember our clotting cascade? We talked about in physio, and you guys talked about probably ad nauseum in several other classes. It's going to show up again here. It should be important when we talk about this in the hematology section. We're going to talk much more about drugs that can affect that cascade, but it will have some, obviously, just a little peek behind the kimono, so to speak. These classes change kind of lecture orders based on CMS. So again, before I had the hematology before this, so some of the stuff may seem like I'm kind of alluding to things that we've already talked about, but that's okay. We're going to cover it in 2 lectures time, so to speak. Anyway. So we can see here, either collagen can be exposed when you have kind of that ruptured fibrous cap there. So you have exposure to collagen that's going to activate kind of that intrinsic pathway. And you're going to have things like ADP or adenosine diphosphate and also thromboxane is going to be kind of directly activating those platelets, right? Because normally platelets, they're kind of this kind of globular kind of shape. They're not really active, but when you see this kind of conformational change, you kind of get these nice little legs that stick out of it. They're going to help to have certain active sites being shown, expressed, that will kind of have other platelets kind of bind up to it. And this is where you get the aggregation here. On the other side, we have tissue factor. It'll be also exposed. This is going to help to activate a lot of those clotting cascade proteins. You have prothrombin being converted over to thrombin. You guys remember which clotting factor that is? 2, absolutely. So factor 2 is going to be really important for this. Also, that will help to exacerbate the platelet activation. This will also kick off that conversion of fibrinogen over to fibrin. Okay, so this is going to be, again, the other big component here where we're having fibrin and platelets kind of all binding together, and this is what causes that the occlusiveness. So just a little bit more in detail on how this is occurring here. So again, you normally have this initiation phase that's happening when you have tissue factor, things like that being exposed to and activating factor 7. We're going to see at 9, 10 are also going to be really important here as well. We're going to see several drugs that can affect this pathway by affecting these particular clotting factors. When we talk about things like heparin, we talk about things like our low molecular weight heparins, we talk about warfarin, you're going to see different places where these different factors can be interacted with and inhibited, right? But ultimately, we're going to see that thrombin is the main thing that gets formed here. This is going to be one of our major players, right? And then you also had this kind of amplification pathway again, because remember that clotting cascade just shouldn't go down. You also saw that a lot of the factors will kind of feed back up and kind of further cause kind of this nice positive feedback loop, so to speak, where you're going to cause a lot more of that thrombin to be formed. And again, more thrombin means you're going to have more fibrin being formed here as well. So thrombin feeding back into factor 11, so you can go down to 9. And you see also here is where a lot of these factors are affecting our platelets as well. So things like factor 8 and 5 are also going to be really important for helping with the platelet aggregation that occurs here. And then further propagation, obviously factor 10 is going to be important here as well, factor 10 and 2, and then more of that thrombin gets activated is going to convert that fibrinogen over to fibrin, right? So again, this will be important where to cause more kind of clot stabilization. This is where things get very occluded. Again, either you need to come in and have a drug that's going to actually break down that fibrin to break apart that occlusion, or you're going to need some kind of mechanical device to actually go in there and break it itself. So again, this is what the cath lab is so important. So basically our goals of therapy here are we're going to try to reestablish that coronary blood flow. So that's going to be our big thing to start off with. We like to relieve chest pain, prevent that progression to MI if possible, right? So if they're having just say like unstable angina and they haven't really had those kind of EKG changes consistent with MI, if we can prevent that occurrence from happening, that would be great. And then obviously kind of in the aftermath, we would prevent development of heart failure. What do you think heart failure happens after this? Basically you're killing off the tissue, right? So your heart's going to fail as long as you cause that ischemia, you cause that tissue to die. Does it come back and regenerate as nice, healthy myocytes? No, it's like it's very fibrotic and gets very not super useful. So again, that's where you see LV dysfunction come about after in the aftermath of acute coronary syndrome. So we want to prevent that, and then also death from occurring if possible. Like I said, unless you really don't like your patient, you took out like a nice life insurance policy on them or something. Anyway. Just kidding, it's very unethical. I know you guys have a class about that. All right, so as far as treatment goes, some of the common pharmacologic therapies we're going to use between STEMI and then non-STEMI acute coronary syndrome. Aspirin, that's going to be one of the first things they're going to take, right? So aspirin is going to be used at the first signs of chest pain. Even if they take 81 milligrams a day as a kind of cardioprotective agent, we're still okay with them going ahead and taking an additional 325. That is to get any other platelets that might be uninhibited by the cyclooxygenation may be still active. We want to go ahead and try to inhibit all those we can. So they'll usually take 325 or 4 baby aspirins. You know, a baby aspirin's how many milligrams? 81. So you can do 4 of those and chew them up. And then that will help to kind of aid with the dissolution and the absorption of the aspirin. We know that this helps to reduce mortality and reinfarction rates. So that's going to be a good thing. So we have evidence to support. You'll see that there's some places where evidence supports use of these drugs. Some places evidence is not going to be super useful. Aspirin is going to be one of these kind of thumbs up. Hey, we got really good evidence to show that these work. Now nitrates. Nitrates like our sublingual nitroglycerin. We're also going to see we have IV options for nitroglycerin as well. No improvement in outcomes, but they can be used for that chest pain relief. So again, patients who have an acute coronary syndrome are very, very uncomfortable, a lot of pain. This can help relieve that pretty quickly. So again, usually they're using sublingual every 5 minutes or so, or they may get like an IV drip hooked up, depending on several other factors like their blood pressure and things like that. Because we said nitrate should do what to blood pressure? Should drop it, yeah. So again, if a patient's already hypotensive because they're in cardiovascular shock, nitrates aren't going to be a great option for them. So again, we'll look at some places to use it, some places to avoid it. And what we see with beta blockers, you want to have they found a 13% reduction in risk of MI among patients with unstable angina and 40% reduction in mortality with MI patients, right? So we know beta blockers work. These are really important. And the question is when do you necessarily start them? Patients already, they're hypertensive, they're tachycardic during this case of MI. This is okay time to use beta blockers. You can get this on relatively early. In a lot of cases, if they are having kind of poor myocardial function because they're having like a massive MI and they're already bradycardic or they're hypotensive, this is something that can wait a little bit to start. So again, look at the patient's hemodynamic status to figure out when it's okay to start utilizing some of these kind of cardiodepressant drugs. The beta blockers can be usually started after MI, and they will kind of get transitioned over to kind of their maintenance therapy for that when they get out of the hospital. So as far as aspirin goes, contraindications are going to be if they have an allergy of this previously, recent GI bleed, or recent intracranial hemorrhage. Obviously, especially when we're talking about our clot busters, any previous history of bleed within a certain time frame is going to be a big contraindication to utilization of these drugs. In some cases, you may utilize clopidogrel or another type of platelet inhibitor in place of aspirin. But again, aspirin is kind of a tried and true gold standard. Most people can tolerate this. But again, nice benefit here: decreased recurrent ischemia, reinfarction, stroke, cardiac death. All that good stuff gets inhibited or prevented with aspirin. As I mentioned with the nitrates, you want to start sublingual therapy, and then once they're in the hospital, then you can consider doing an IV infusion of this. You have to be really careful with the dosing. There's different places they'll use things like micrograms per minute or mics per kilo per minute and things like that. And so again, always be careful with your units. I've seen some errors where a whole bottle of nitroglycerin got infused into an MI patient within about 5 minutes due to the rate being put in incorrectly as the wrong unit. So it was a little bit of a boo-boo. Guy did fine anyway. You probably don't want to say like during a deposition, it was a boo-boo. But it's one of those things where be very careful. Make sure your units are correct when you're discussing dosing. I've seen several cases where they say, hey, start dopamine at 20. 20 what? Mics per kilo per minute, mics per minute, 20 ducts. Like, what are you talking about here? So units are super, super important. Looking as far as adverse reactions go, hypotension is a big one, right? Because we know this directly is going to cause vasorelaxation, it's going to cause blood pressure to drop. Headache, obviously, going to be a big side effect of that hypotension is occurring there, and that reflex tachycardia. Now, if your patient's already tachycardic and that's already causing increased oxygen demand, this might not be a good option for them. So kind of think about these kind of things. Think about whether or not this is going to exacerbate your symptoms. And obviously, as far as contraindications go, or if they're hypotensive, you don't want to start it, and then if they're on a phosphodiesterase inhibitor. So again, you have to be careful. It's one of those questions that EMS should be asking the patient if they get a call, a guy's having chest pain, ask if they're on any of these medications for erectile dysfunction. If they are, you typically want to avoid the nitrates due to that risk for really big drops in blood pressure, see decreased oxygen delivery to the heart. That's going to worsen your ischemia, right? So you have to think about those sort of things. Make sure you're not going to cause any of these really significant drug interactions, which can be a problem because some of the some of the phosphodiesterase inhibitors are going to work for, say, like a 24-hour period. It's like a nice Viagra, 24 hours, and you're generally it's going to be out of the system. Something like a Levitra that can work for like 72 hours or can work for the better part of a weekend is going to be precluding you from using nitrates for a decent period of time. So again, you have to think, when's the last time you took a dose can be important as well. So anyway, benefits here, no mortality benefit, just relief of chest pain, right? So aspirin, improvements in mortality, nitrates just for symptom control. Again, I mentioned beta blockers. You can start off with IV therapy first and then switch over to PO eventually. Again, this is typically one of the discharge meds that they're going to be on when they leave the hospital. But be careful if they're already bradycardic or hypotensive. Be careful if they have heart block, or again, make sure we're using a cardioselective beta blocker if they have severe reactive airway disease and have asthma. Usual kind of agents here that we can use as far as IV goes, things like labetalol is a good option. Things like metoprolol has an IV option as well. Those are kind of your go-to that you can utilize here. I've even seen some cases of another drug we talked about previously called esmolol as another kind of cardioselective agent. Again, it's very nice because it is very titratable because it works has a very short half-life. And so you give it via continuous infusion, you can titrate the dose very easily to get their blood pressure and heart rate right where you want it. And so we see, as far as benefits go, this is another one that causes mortality benefits here, where we see reduction in early and late mortality, reduction in infarct size, decreased heart failure incidence. These are all going to be really good things that you want to send your patient home on when they leave the hospital. Morphine. So again, you guys ever heard of the MONA mnemonic for drugs to get to patients with having chest pain? So we mentioned, obviously, M is going to be morphine, right? We mentioned O is going to be oxygen, so patients should also get oxygen. Kind of don't listen here as the pharmacologic agent, even though kind of technically I would probably consider it to be. So what's the N? Nitroglycerin. Aspirin is going to be the A there, right? So MONA is the thing you think about as patients with chest pain, acute coronary syndrome. They should be getting all these drugs. Now, morphine is one of those things where what do we use morphine for? How does that affect the heart? It really doesn't, right? This is for pain control. Again, I mentioned these patients are in a lot of pain. Hopefully the nitroglycerin can fix their pain issues, but a lot of cases it does not. We can give morphine instead. This is an opioid analgesic and can affect our opioid receptors. We'll talk more about this in Pharm 2 in the next semester. But this is useful for chest pain unresponsive to nitrates. So start with a nitrate, see if that works. If not, then you can switch over to something like morphine. It doesn't matter which opioid you use. You could use Dilaudid or hydromorphone. You could use fentanyl. It doesn't really matter. Morphine is fine. Now, again, there is some worry about maybe increased mortality in some cases. So again, this is not a absolutely have to use drug. If you can get away with not using it, then that's fine as well. Only big things to worry about is that they have a previous allergy to opioids, especially to morphine itself or like codeine. We'll talk about allergies later on, but you'll see there's some cross-reactivity during with certain opioids. And then this can actually cause hypotension as well. Morphine causes a lot of histamine release, much more so than it does in a lot of other opioids. And so histamine, we know, can do what to blood pressure? Can decrease, right? So think back to your anaphylactic shock kind of talk where we saw that hypotension is a big component there. This histamine can do the same thing here. So again, patients already hypotensive may not be a good option for them. All right. So then obviously our clotting cascade, this is going to be really, really important to have a good understanding of when we talk about drugs that are going to be affecting us directly. We'll cover this again when we get to that hematology section, and we'll talk much more about that in detail here. But obviously we have our intrinsic system, or extrinsic system. This can be affected by different agents depending on what we're looking at. But the big thing to focus on is obviously going to be factor 2. That formation of thrombin. Factor 10 is going to be another kind of big component here as well, because that has a direct effect on activating thrombin. And so the other factor here is what we're going to see is that obviously thrombin converts that fibrinogen over into fibrin, which is what's causing our clot. How do we get rid of that though? We have a product called plasmin. Plasmin is going to be one of our natural, because again, if you had just fibrinogen being formed in your body, clot all over, and that wouldn't be very good. You'd be dead. So we have to have a natural way to have anticoagulants in the bloodstream that can help to break down these fibrin clots. And so that's going to be used with plasmin. Basically, what you see here is you're going to have plasminogen is the precursor to plasmin. That gets activated by a product called TPA, or tissue plasminogen activator. Right, so that kind of makes sense as to what that enzyme does. But you're going to see that this is going to cause conversion of plasminogen over to plasmin, and this is going to break down that stable fibrin into fibrin products. Okay, so again, this is the important counterbalance to forming fibrin. You got to have breakdown of that, and that's what plasmin is going to come into play. So we talk about our clot busters or our fibrinolytics. These are the drugs we're talking about. Are things that are going to be either directly or indirectly activating this plasmin to help break down the clots for us. Okay. You guys heard that term clot buster before? Yeah. Okay. A second. So again, fibrinolytics, they're starting to go a little bit by the wayside. There's certainly some other indications we can use these, but they're not going to, if you think about, back in the day, back before cath labs were so kind of prevalent, back before we had really good ability to get patients into, that door to balloon time down, this is what we had, and we were giving these fibrinolytics that bust these clots, hopefully prevent death from occurring. And the problem is, if I give these fibrinolytics, I'm giving it via IV, where does that work at in the body? Everywhere, right? So it affects the clot and in the coronary vessels. It's also going to affect everything else. So again, one of the big primary problems with these drugs is bleeds, right? So this is one of those things where again, it's very dangerous drugs. You are going to see that there's going to be a big list of contraindications you absolutely have to screen patients for. Otherwise, you can end up killing somebody, right? Because these are very, very dangerous drugs. The other big place we're going to use fibrinolytics. You guys know any other cardiovascular disease states we might use this? Maybe you're having a big blockage of blood to a very vital organ. Stroke, yeah. So this is the other place we might actually see use of these fibrinolytics. Probably more so in the neuro side of things than you will in the cardiac, because cath labs have been become so prevalent. But anyway, so basically what this is going to do is you're going to have this promote this conversion of plasminogen to plasmin. One of the big enzymes that will be responsible here as well is going to be called tissue plasminogen activator, or TPA. We'll look at that pathway in just a second. And this helps to lyse fibrin, fibrinogen, and then factors 2, 5, and 7, where 7 is really important for which pathway? That tissue factor. It's an extrinsic pathway. But 2 and 5 are also going to be very important for helping to promote that fibrin formation. So again, this is very, very good. We want to help break these down, especially when we have a potentially life-threatening clot forming. So we're going to see there's several different ways we can do this. So for instance, there's a product called streptokinase, an enzyme that kind of forms a stable complex with plasminogen that helps to actually expose this catalytic site. So again, usually you're going to find that plasminogen is going to be circulating in an inactive state, which is good because again, we don't want to necessarily break down fibrin unless it's necessary. But when you have streptokinase comes in, it's going to cause this exposure of catalytic site. That's going to allow for the reaction to occur where you convert the plasminogen over to plasmin. TPA is going to be able to bind to that plasminogen bound to fibrin. So again, this is important whether it's attacking all fibrin or if it's going to be fibrin actually bound into a clot. And so this is why we like TPA, and we're going to use this pretty frequently because if you have a clot actually forming and that fibrin is stuck there, it's bound, this is going to help to convert it over to plasmin, and it's going to lyse that clot. So it's going to be very useful for that. So imagine you have things like streptokinase, you have plasminogen. Once you have that kind of that binding, that conformation occur, this is where you have that activator complex show that catalytic site gets exposed. TPA is also, there's another enzyme called urokinase we'll talk about briefly, where this is going to cause that conversion of plasminogen to plasmin. So again, this is the active product we're looking for. We want to stimulate that conversion over to plasmin. All right. So a couple fibrinolytics we have streptokinase, we have urokinase. These are both going to be activating both circulating and bound fibrin, right? So it's going to be affecting more of kind of in a systemic fashion all the fibrins around there. We're going to find that things like tissue plasminogen activator, TPA, there's another product called retiplase and the tenecteplase. These are going to be better because these are more specific for fibrins bound to an actual clot, which is good because it's going to have to reduce some of those side effects like that bleeding we're talking about by only affecting places where clots have already formed. Make sense? So again, bound fibrin is the place we want to actually be active at. We'll see that pretty similar responses as far as efficacy goes, but again, adverse effects are going to be very similar as well. Because typically, if you have a clot formed somewhere, you probably wanted to stop that blood flow anyway. So, but even though you're attacking that bound fibrin, it is still going to be potentially causing bleeds. So as far as adverse effects go for all of these, bleeding is going to be one of the big things. So you can see hemorrhagic strokes develop from this. You can have bleeding in all sorts of places. The other thing to watch out for is some of these allergic reactions. Some of these are formed kind of in a recombinant fashion from like bacteria and things like that. And so there's a risk for having some allergy seen with these anaphylactic reactions. So you got to worry for that. And then also some risk for ventricular arrhythmias. And again, if you think about a patient who's having acute coronary syndrome, what are they already at risk for having? A ventricular arrhythmia, right? If you're causing that heart tissue to die off, you're promoting risk for these kind of reentrant arrhythmias and ventricular arrhythmias to occur. So again, you're already giving it to someone who's predisposed to that to begin with. It's kind of as a chicken or egg kind of phenomenon here, but again, it could potentially exacerbate that. So this is really important here to kind of note these contraindications, right? So these are important things to note. So if a question came up on a test of like, okay, a patient has X, Y, and Z going on, they had surgery in the past like 3 days, what's going to be the best drug for them, right? So these are kind of things I want you to be aware of. So they had surgery recently. This can include things like organ biopsy, puncture of a non-compressible vessel. These are kind of the checklists you're going to be going off if you ever decide you want to use a fibrinolytic for a patient, right? So you'll see this a lot with like the neuro team or the cardiac team when they're going through this. Any sort of thing like this is going to preclude you to having more bleeding risk. This would contraindicate you from receiving this drug. Any serious gastrointestinal bleeding within 3 months, also a big risk. History of hypertension. This one's kind of interesting. If they have a history of hypertension, especially a diastolic greater than 110, so again, that's diastolic, not systolic, greater than 110, you have a chance to get this down. You can actually give a patient antihypertensive, usually IV, something like hydralazine or something like enalaprolat or like a beta blocker. You can actually get their blood pressure down. If you're successful, then you can potentially still give them a fibrinolytic. But if they, usually you can kind of give them 2 chances, give them 2 doses of antihypertensive. If they're still high, then you would go ahead and preclude use from these fibrinolytics. If they have any active bleeding or hemorrhagic disorder, obviously that makes sense. They have a previous cerebrovascular accident or any kind of active intracranial process like a tumor or something like that, I would also preclude use. Aortic dissection, acute pericarditis, and then any like allergic reaction, the streptokinase previously, or like a pregnancy. So these are all things we kind of cue in, like, hey, this is not the drug for these patients. We need to do something else. Again, probably the cath lab. So I'm not going to talk too much about streptokinase because we actually don't use this one too commonly anymore. Just know that this one, you ended up seeing patients can actually develop allergy to this one pretty significantly. So again, we don't really use it here in the US, so I'm not going to really probably ask any questions about it. Urokinase not also used in the US. Again, I'm just kind of putting it here just in case you ever do see it talked about. You at least have some idea for what it is. So again, not too much. But these are the 3 that I do want you to focus on because this is going to be more of the ones we see used in the U.S. more commonly. These are going to be the ones that are attacking that fibrin-bound, the clot-bound fibrin essentially. So we have alteplase or activase. This is basically a recombinant TPA that's been formed from these Chinese hamster ovary cells. I don't know why they got so specific and said, you know what, Ecuadorian hamster cells, no good. Chinese hamster ovary cells, those are the money cells. I have no idea, but anyway, this is TPA because it's recombinantly made. It's also very, very expensive. Okay, so we can use this for other indications as well. So a lot of times, if you ever have a patient who has like an occluded line, so if you have like some like clot formed in a line, oftentimes you can use TPA to actually help to dissolve those, and that way you can save a line potentially, right? So if you think like a central line a patient has, if it gets occluded, you can give this to help kind of break that up. Usually the dose is a lot smaller, which is important. You don't want to give them like a full dose because otherwise you can see that increased risk for bleeding. But if you ever see alteplase, again, this is just a recombinant TPA. Essentially, this works the very same as what your body produces anyway, right? Also, retiplase does a very similar thing, but it's made from E. coli cells. And then tenecteplase, or T in case, as a brand name here. Again, this one is going to have basically just a little bit of difference in the amino acid sequence, but again, works pretty similarly. A little bit longer half-life over TPA, or the alteplase, as I mentioned, and can be relatively resistant to PA. This is I can't remember the full name for that, but this is an inhibitor molecule that actually will prevent TPA from actually being activated. So again, kind of the additional benefit may last a little bit longer. I see tenecteplase used occasionally more for myocardial infarctions. If the patient was not able to get to a cath lab, that might be one option there. But by and large, I see a lot of TPA or alteplase being used pretty commonly. So like for instance, we have an interventional radiology program at Nemours. They use this drug pretty frequently, either for line occlusions or they'll use it for certain other things. Like in some cases they may have, I'm trying to think what it, They'll use it intrathoracic for, I can't remember which indication, but sometimes we'll have like intrathoracic administer TPA to help bust any clots that are there. So again, different places you might see this being used than just like MI, but this is kind of where we mention it here. So again, our indications, and again, the timing is really important. We'll talk about this when we talk about stroke as well. But the time, as we mentioned, time is muscle or time is tissue, and so you need to make sure you're using these drugs early on, because otherwise they start to lose benefit. So again, if the patient is too elderly, you typically see less benefit, more risk for side effects. So again, less than 75 years, within 12 hours of symptom onset, typically is where we're going to see the most benefit here, especially with STEMIs. And STEMIs again have a little bit less evidence to support that use. Relatively few patients are receiving it for this particular indication, mainly because the risk for bleed is so high. So especially, anywhere between 0.5% to 7% of people will have some sort of clinically significant bleeding, and then around, anywhere between 0.4 to 1% intracranial hemorrhage, right? So I can treat your MI, but there's 1% chance you might have a stroke. Not great odds, right? So this is one of the reasons why we like to avoid this if we can, utilize something that may be a little bit more invasive, but can be much more targeted. And so in some cases, you may even see in the cath lab, they actually have catheter-guided administration of some of these fibrinolytics, which is really nice because you give a much smaller dose and you give it right to where you need it and not really anywhere else. Okay, so it's kind of, you may see that occasionally if you ever go work in the cardiac sector. Okay, does that make sense so far? Okay, so some other agents you may see being used post-acute coronary syndrome, you may see glycoprotein 2B3A inhibitors. We're going to talk about these when we get to the hematology section, so we'll talk about these much more. This is going to be really important to help prevent platelets from forming cross bridges. So platelets like to aggregate the site of a bleed or site of one of these plaque ruptures. This is one of those kind of cross links that is really important. So we'll talk about 2B3 inhibitors later on. There's also this P2Y12 receptor antagonist. This is where that clopidogrel fell into. Again, we'll talk about this in another section. We can sometimes use this for like clot prophylaxis, and because obviously one of the things that you can do when you're having you go to the cath lab, stents being placed. And what are stents? Yeah, it's kind of a metal mesh that basically kind of keeps the vessel patent. Again, anytime you're introducing hardware into a patient, that's more likely to see things like reactions to it. You can see clotting occur, and so this is why we have things like clopidogrel or these platelet inhibitors blocks a specific site on that platelet to prevent clot formation from occurring there. And then we'll talk about heparins later on. This helps. Sometimes you'll see patients who are coming in for an acute coronary syndrome. They'll be put on a heparin drip or some other drug similar to heparin to help prevent, kind of help with the antiplatelet effects from a different pathway, and kind of help to prevent that clot from getting any worse. So again, much more detail. We'll talk about that later on. Just a picture of a stent being placed. See here they kind of go in the balloon, kind of occlude it out. And so you imagine having that kind of bare. So there's two types. Have you talked about stents at all? So there's bare metal stents and there's drug-eluting stents. Drug-eluting just means it has drug implanted into it to help prevent clot formation and things like that. This would be an example like a bare metal stent, where basically, having that bare metal in there, just similar to if you have like a mechanical heart valve, that's more likely to see things like, platelet aggregation and whatnot. So this is why you have to give either antiplatelet drugs or anticoagulants to prevent that from happening. Because obviously if it starts to occlude here, then you're kind of screwed a little bit, because in the patient, it's hard to open that back up anymore because you already have that stent there. So again, you have to go in and kind of break the clot up. Anyway, okay, so when looking at in-STEMI, you're going to see that the early treatment is very similar. So you're still going to do your Mona, you're still going to do oxygen, your nitroglycerin, your aspirin, all that good stuff, morphine if needed. We typically do not use fibrinolytics. There's just too big an increased risk for bleeding, not necessarily a whole lot of benefit compared to the actual STEMI. And what we'll see is we actually will utilize a drug called enoxaparin. This is a low molecular heparin. We'll talk about in the heparin section a little bit later on. So you may see that used a little bit more occasionally. And then we'll talk about glycoprotein 2B3A inhibitors later on as well. This would be really handy if I talked about hematology before this section, but again, it is what it is. But you'll get a whole lecture just full of that. Okay, so any questions on acute coronary syndromes? All right, so moving on, we talk about chronic heart failure. So what is the reason a lot of people develop heart failure? Usually ACS is a big one, right? So about 50 to 60% of cases usually had some sort of ischemic heart disease that led to a dysfunction of that left ventricle. Hypertension, kind of chronic, high afterloads can also lead to this. Some cases you may see even other types, other etiologies here. You can have things like alcoholic cardiomyopathies, drug-induced in some cases. There are actually a group of chemotherapeutic drugs we'll talk about towards the end of the section that can actually induce a cardiomyopathy and lead to heart failure. There's actually a lifetime dose cap that you can hit for certain drugs drugs, and for cancer, that once you pass that, then the risk is too high and you can't use that drug anymore. But anyway, there's systolic dysfunction and then diastolic dysfunction. We're going to primarily focus on systolic dysfunction because this is the one that gets more, it's much more common, and we have the pharmacotherapy here to use for this. And so big thing here is decreased contractility of that left ventricle. A lot of it has to do with either that left ventricular hypertrophy or dilated cardiomyopathy, or just that loss of muscle mass. It could be due to ischemia or something like that. And again, classified or reduced or assessed as a reduced ejection fraction. So say you get to less than 45%, leaving a lot of blood left over in that ventricle, that would be considered poor ejection fraction. The diastolic dysfunction tends to be more due to impaired relaxation. We can see that this can be mostly due to things like left ventricular hypertrophy. So if you imagine that the wall gets bigger, gets thicker and stiffer, it's going to be less likely to relax and allow for a lot of that blood volume to come in there. Or it could be due to things like ischemia. Some people think it may be due to issues of calcium not being able to get back in the sarcoplasmic reticulum quite as well. I can't really relax quite as much. But what we see here is decreased ventricular filling and thus worsened cardiac output for those patients. Okay. In some cases, you may have patients with heart failure symptoms with preserved ejection fraction. This is generally due to that diastolic dysfunction they have there. So again, impaired relaxation versus impaired squeeze, essentially. So typically what we do is a compensatory response. So your cardiac output's low, right? So how do we respond to that? So there's a couple things we can do. We can try to increase preload, right? So that we do that primarily by activating that renin-angiotensin system. So we can increase sodium and water retention, right? We can do things like vasoconstriction, so we can increase our TPR to make up for that lack of cardiac output. And then we can also try to make the heart work harder, right? So again, you can see how these are all kind of cyclical, kind of adding insult to injury sort of things, where again, it just gets worse and worse and worse, and try the compensatory mechanisms kick back up even more, make the heart failure worse, and kind of goes around that cycle. But again, you can do things like increase cardiac contractility and heart rate by increasing sympathetic nervous system activation, and again by hypertrophying the muscle by helping to squeeze harder. That can again be useful as well in the short term. Again, sorry, this is kind of not quite centered, but again, you can see how all these things are going to kind of feed into one another and just kind of lead back to worsened cardiac output in the long run. So I won't kind of talk about that too much. And always freeze. Get rid of those. Anyway, so again, looking at the signs and symptoms can differ based on if you have kind of more right-sided versus left-sided heart failure. Have you guys covered this in already, Dr. O? Okay, so I'm not going to belabor these points too much. Just know that a lot of times we're going to focus more kind of on the left-sided heart failure, but things like dyspnea on exertion, poor exercise tolerance, orthopnea, tachypnea, all these kind of different things can be happening here. Again, why do you think they get pulmonary edema? Kind of that backflow pressure into the pulmonary side of things. So again, you can see that pulmonary edema happening in these patients. Again, they're also holding on to a lot more salt and water. So again, you're going to see a lot of edema happening in these patients kind of all over. So some of the precipitants of this decompensation, right? So a patient can live with a CHF for some period of time. Eventually, they're going to develop a decompensation. A lot of it can be due to things like lack of compliance with medications. So we're going to see that they don't stay compliant with a lot of their medication therapies. They can have some issues where they have pretty precipitous drops in LV function and can leave themselves in the hospital. Things like arrhythmias, uncontrolled hypertension can all worsen this. And then fluid overload is going to be one of the big issues here. So either if they're on inappropriate medications, they're not treating the fluid overload appropriately, or maybe they're just not working quite so well. But other things, pulmonary infection, emotional stress, all of these can be kind of precipitants to having acute decompensation. So looking at non-pharmacologic therapy, obviously we want to get them active. We want to kind of reduce that sedentary kind of lifestyle. The other big thing is going to be low salt diet typically. If we can try to limit how much salt and fluid they're intaking, that's going to be beneficial for them because that helps kind of get rid of some of that volume, can help with the hypertension, can help with a number of different issues there. So again, usually limit sodium intake maybe 1 to 3 grams a day, limit fluids less than 2 liters a day if possible. All right, so as far as diuretics go, and again, when we talk about CHF, there's going to be some drugs that work on improving mortality, some drugs that are just going to be more for symptomatic relief. And so it's important to kind of get an idea for what all your patients should probably be on from a mortality standpoint, and then things they should only be on if they have symptoms that kind of warrant it. And so as far as diuretics go, diuretics can be useful because what do they do for a CHF patient? get rid of that fluid, right? So they're going to help with the edema, pulmonary edema. They help get rid of a lot of that extra fluid. We're going to find that as far as thiazide diuretics go, they typically are not potent enough to really help with that fluid overload for a lot of heart failure patients. It can still be useful as an antihypertensive, but not really great to get rid of all that kind of fluid. Loop diuretics, though, these are going to be mainstay of therapy. These are going to be able to get rid of a ton of fluid. They're going to be able to decrease that sodium and water retention, obviously by affecting what part of the nephron? The loop of Henle, right? And so by affecting that, you're going to be able to get rid of a lot of fluid, a lot of salt there, okay? One way we can help to monitor for this is to look at the patient's weight, right? So you can just kind of monitor their weight. If they start to go up by a few pounds, you can pretty much know they're starting to hold on to a little bit more fluid. So you typically, greater than a pound a day, for instance, over several days, usually indicative of them kind of holding on to a lot more of that fluid there. And so again, diuretics are only for symptomatic relief. You can give them all the loops you want, but it does not improve mortality at all. It's really going to be for just that they just notice they're getting a lot more of that kind of edema forming, or their lungs are just starting to get real junky. Like those are all things we can use to help signs to get rid of that fluid. And so not mandatory therapy, only if they need it to get rid of that fluid. You can use this on a PRN indication. Some people are just kind of so bad at retaining that fluid they may be on this daily. It just depends on the patient here. Now, one of the things, I don't know if I'm next slide. Yeah, so one of the things you may notice, did I mention loop resistance? What is loop resistance? So that's where you can use a loop diuretic, but you may notice that it becomes less effective over time. And why do you think that happens? So possibly, yeah, it's part of it's the renin-angiotensin system, because you can have things like aldosterone become upregulated, which will hold on to more salt and water. What's another thing?
The other parts of the kidney compensate.
Yeah, so what is distal to the loop of Henle? The distal convoluted tubule, right? So I'm trying to give it away. So the distal convoluted tubule can actually start to kind of work in overdrive to try to retain a lot more of that salt and water, right? So again, the kidneys are sensing, hey, we're losing a lot of salt and water here because these loop diuretics. Let's try to hold on to more. And so it's called loop resistance you can have there. So how would you fix that? Give them a thiazide diuretic. So I mentioned if you add on a thiazide at that point, you can actually help to get rid of a ton of that extra fluid. I mentioned if patients have poor kidney function, metolazone is a good option for that because it still works even if their renal function is less than 30 mL a minute. So those are all really good options you can do there. So again, if they notice loops aren't really working so well, add on a thiazide, it's going to start to work great again. So ACE inhibitors, these are going to work by helping to decrease preload. Right, so they're going to help to decrease the effects of that renin-angiotensin aldosterone system. They're going to decrease afterload. They help to decrease that sympathetic activation, and they help with this helping to prevent that hypertrophy, the dilation, the remodeling. Again, it will help to slow progression of disease, does not reverse it, but it can help to slow it down. So again, do you think these would have improvements on mortality? Absolutely, yeah. So ACE inhibitors are absolutely going to be recommended for patients with CHF. Again, we're going to see these hemodynamic improvements. Their blood pressure should help to get under control. So help to improve their exercise tolerance, decrease heart failure symptoms. These are all going to be good for both symptomatic control and for helping to extend life for these patients. We even find they have fewer hospital admissions, which obviously is going to be really important to people like insurance companies and the patient. And then prolonged survival is kind of the big thing there. So ACE inhibitor, if they can't tolerate an ACE inhibitor, you can use ARB, totally fine. Some problems though, if they have poor kidneys to begin with, we mentioned that some of those patients are really dependent on Ang2 for that squeeze of that efferent arteriole. So again, start low dose and gently titrate up, depending on how they can tolerate it. Obviously, hypotension could be another big risk for there as well. And then again, looking at potassium. So if you imagine patients who are on a bunch of loop diuretics to get rid of fluid, what does that do to their potassium? It can decrease it, right? So then if I put on an ACE inhibitor, that's going to do what to my potassium? Helps to increase it back up. So again, there's going to be kind of a delicate balance here where you're looking at their potassium levels based on the drugs they're on. You put them on a loop, it's going to drop. If I put them on potassium-sparing diuretic, it's going to go up. This is why I asked that question on the test. You guys remember that one? Right? So which ones affect potassium in the body? You need to know which way the potassium is going to go, because the risk of having too high or too low potassium can be pretty catastrophic for some of these patients, right? Hyperkalemia can kill somebody. Hypokalemia can kill somebody. So you got to be really careful with that. So watch potassium levels. Also, cough is due to that bradykinin buildup. What could I do to prevent the cough? Switch over to ARB. That would be a good option. And then obviously angioedema would be a risk as well. All right. Now, beta blockers. Typically, we mentioned that beta blockers sound like a bad idea for CHF because that should just depress left ventricular dysfunction, right? It should help to reduce your ejection fraction even further. Why is this a good idea, though? Well, we do see some mortality benefits. And so we had some large studies we were doing on these CHF patients where basically we've looked at 3 different beta blockers. We have carvedilol, which again is a 3rd generation beta blocker. We have metoprolol, and notice this is the XL formulation. This is the one that's going to be lasting. You just give once a day and it lasts throughout the day. And then they looked at bisoprolol as well. So these are kind of the 3 main beta blockers that have indications for treatment of CHF. Okay. So again, if I put like on a question, which beta blocker would be good for this patient, I put propranolol, you say no go, don't want that one. I want either metoprolol XL, I want carvedilol, or I want bisoprolol. So the keys here, typically patients need to be really stable with their CHF prior to initiation. Oftentimes they're going to be, say coming into the hospital for an exacerbation, you kind of get them topped off while they're there, get them stable, and then you can actually add on a beta blocker in-house. That's usually the safest way to do it because you worry about them obviously having decompensation if they were to have too big a dose or they go too rapidly with it. Okay, start with very low doses and titrate up over about 6 to 8 weeks or so, and then the guidelines will give you actually dose recommendations for how high you want to drive up the dose for those patients. All the time you're monitoring for symptoms, worsening heart failure symptoms, if their exertional dyspnea gets worse, or if they notice fluid buildup, any of those things, you're going to be looking for that. So again, benefits: improved exercise tolerance can be good. You see some hemodynamic improvements, especially like getting rid down that afterload by helping with the blood pressure, and then you can see slow disease progression. So they found that patients who are on beta blockers with CHF, these 3 that I mentioned, they tend to have decreased hospitalizations, decreased need for transplant, and decreased mortality. So again, all very, very beneficial for your patients. So typically, they have class 2 through 4 heart failure. And when we talk about classes of heart failure, what does that mean? Yeah, it usually has to do with symptomatology, right? So again, obviously class 4 is going to be a lot worse than class 2, but these are going to be, and again, what class heart failure do you guys all have? If you look at the definition, technically it's like 1, like we all kind of have some degree of heart failure. I guess I'm probably failing a lot more than you guys are at this rate, but given my birthday. But anyway, basically though, if they have any degree of symptomatic heart failure, like these beta blockers are going to be beneficial for them because again, it can help slow that progression, helps hopefully stave off the Grim Reaper's final appearance, right? Hopefully they're going to live for longer, and they'll be in the hospital less, hopefully. So again, patients with ACE inhibitors and beta blockers, these really are the 2 kind of go-to drugs. Improvements in mortality, these are the ones that patients should be on. Okay, so some other drugs we have here. Anyone ever heard of digoxin before? Anyone know what plant you can get this from? It's a very common plant that grows in Florida. Yeah, foxglove is one, absolutely. It's also lily of the valley. The oleander is a big one. If you're ever like driving along the highways, 417, you see all the oleanders that are there on the medians. Those are super toxic, so don't eat them. Basically, the digoxin is a drug. It has a steroid kind of like structure we see here. You may see it also referred to as like digitalis. It's kind of another flavor for these digoxin-like compounds. But basically, we're going to find that this is going to be it's kind of a sugar molecule added onto the steroid group, and this is going to be useful for it used to be kind of more mainstay therapy for CHF, and nowadays we use it a little more sparingly, as you'll see in just a few minutes here. So, how does digoxin work? So this is going to be important when we talk about this in terms of the antiarrhythmics in just a little bit, probably in the next section. Basically what digoxin does, it actually inhibits the sodium-potassium ATPase pump. Everyone's favorite pump, right? I don't know, it's my favorite pump. Anyway, so you're going to inhibit the sodium-potassium pump. Again, main purpose is to drive sodium out of the cell to bring potassium into the cell. So what that does is by inhibiting this pump here, what's it going to do to intracellular sodium concentrations? Should go up, right? So it should go up, and then also is going to cause extracellular concentration of potassium to go up, right? Because not as much of it is being shown. That'll be important when we talk about changes in electrolytes in a few minutes. So sodium is going to stay within the cell. This is going to cause this transporter here to work in kind of an overdrive because you have more sodium. It's going to force more sodium out of this transporter. It's going to bring more calcium into the myocyte. So we mentioned that calcium is really important in the myocyte because it does what? Helps to increase contractility, right? More calcium you need for the actin-myosin complex to form. So by having more calcium within the cell, the heart tends to beat stronger. So this helps with the contractility, should increase that contractility. That is the first reasons why we use digoxin for CHF, because we know the issue was they have poor left ventricular function. Well, let's go ahead and give them a drug that helps the heart to beat harder. So again, we'll realize in a few minutes why we don't use it that way really anymore, but this is kind of the predominant way as it works as an antiarrhythmic, by blocking sodium-potassium pump. So As mentioned, it's a positive inotropic agent, which means it's going to be helping to increase that force of cardiac muscle contraction. Nowadays, we use it more for this kind of neurohormonal kind of mechanism here, where basically what we see, and typically we'll see that our levels we're shooting for is a little bit lower. This is another drug we do that therapeutic drug monitoring on. We actually measure levels. But here we're going to use this at lower doses, where basically we're decreasing both sympathetic and increasing parasympathetic nervous system activity. Generally good because that's usually an overdrive for CHF patients. It helps to resensitize that baroreceptor reflex. It helps to reset where that pressure set point is for that, help with the blood pressure. It also helps decrease the renin-angiotensin aldosterone system. So again, by looking at this, you may think it would help with mortality. In actual practice, they find that it's really only going to be good for symptomatic control. It does not really help with helping these patients live for longer by any means. So, as I mentioned, blocking that sodium potassium pump can help with that baroreceptor reflex, lead to a decreased heart rate, which is again can be beneficial, helping to decrease oxygen demand, decrease kind of the work the heart's having to do. Also see the increase in that parasympathetic activity. You guys remember what happened if we activated muscarinic receptors on the heart? Yeah, decrease it, right? Because we give things that block those muscarinic receptors to increase heart rate. We'll talk about atropine. We'll talk about things like ACLS. Anyway, decrease in sympathetic activity, also decrease blood pressure, decrease heart rate, and then can help us to have kind of more time for the left ventricle to fill, can let it work a little bit better. So you see ultimately an increase in cardiac output due to this kind of better pumping actions. So these are the reasons why we use it for this kind of newer mechanism, this neurohormonal kind of effect. So other things, renin-angiotensin system, decreased remodeling, and the levels we're shooting for are typically a lot lower. I'm not going to ask you specifically what level. If I ask a question, though, I might like put what the reference range is on there, but just for your reference here, usually at 0.5 to 1 is kind of the range we're shooting for. We used to shoot a lot higher. We used to do like 0.8 to 1.5 or so, but lower levels are okay for our patients. So you see improvements in symptoms, improvements in exercise tolerance and quality of life, decreased number of hospitalizations, but no survival benefit. Okay, so it's important to note there that this is good if they're having symptoms despite being on their beta blocker and their ACE inhibitor, but it's not going to help them live for any longer. May keep them at the hospital, right? May help them prevent a decompensation, but won't necessarily improve their mortality. That's based on the studies we have so far, right? Not to say that you couldn't do another big study and find conflicting results, as we know from watching EpiBio, right? Hopefully everyone's watching their EpiBio. Anywho, so the place in therapy here, again, no benefit or no evidence for slow disease progression, but we can use it in patients who are symptomatic and they're on optimal doses of ACE inhibitors and beta blockers and diuretics, right? So once you kind of get those three other classes on board, kind of get them topped off, then digoxin can be a useful kind of adjunct. We'll see that also digoxin is useful as an antiarrhythmic, namely for atrial fibrillation, so we may use it for that potentially in patients who have kind of concomitant AFib plus CHF. And then also if they're symptomatic heart failure with systolic dysfunction, that could be another option as well. So digoxin, we don't like to use it too much anymore. It's a really old drug. It's kind of like theophylline if you think about it, back to the asthma section. It's an old drug. Even though it can be effective, it is a lot of side effects associated with it. And so we see that a lot of GI side effects, a lot of nausea, vomiting associated with it. But also if you don't watch your levels, they can get too high and cause a lot of these CNS effects. So it can cause things like photophobia, blurred vision, xanthopsia. Anyone know what that is? Yellowing of the vision, yeah. So if you ever hear someone who's complaining of like yellow-greenish kind of vision or halos around lights, that usually is a sign of digoxin toxicity. You can see with that. So you got to be careful to overhear that. So also you can see changes in mental status, can have delirium, fatigue, all this kind of thing. Normal dreams associated with this. So again, these are typically signs that you probably should check the levels, see kind of where they're at. Because either the level's too high or they're just a little bit more sensitive to it. So other things you can see here include things like bradycardia. You can see these digoxin-induced after depolarization. So it's kind of typical things you see with digoxin as an antiarrhythmic. We'll talk more about this a little bit later on when we get to the antiarrhythmic section on part 4. And then as far as contraindications go, obviously they have advanced heart block. If they are, they have bradycardia already, any kind of PVCs or ventricular tachycardia, probably want to avoid digoxin because then, again, this can all aggravate those arrhythmias potentially. So you got to be really careful. Hyperkalemia is also another contraindication because we mentioned by blocking that sodium potassium pump, where does potassium tend to get shifted to? Outside the cell. So you would imagine your potassium levels would increase when you have digoxin on board. That's something that we certainly see with that. Again, hypomagnesemia, hypercalcemia, these are all things that can exacerbate arrhythmias potentially, and then we want to avoid this in Will Parkinson White. We'll talk more about this when we get to the antiarrhythmic section a little bit later on. Okay, and then just real quick, if you ever have too much digoxin on board, we actually have an antidote for this. So I mentioned this real briefly. This is a digoxin immune fab, or an FAB. It's basically a recombinant antibody we have formed to bind up digoxin in case it's causing a lot of toxicity. This is actually made from ovine sources. So what type of animal is ovine? Sheep. Yeah, so it's actually made from sheep antibodies. We've hyperimmunized sheep against this digoxin, and then we'll take the spin down those little antibodies. We actually cleave them off, have a little bit shorter portion, so that it doesn't cause much anaphylaxis reactions, essentially. So this is a really good drug. If you ever hear Digibine being used, it's typically to bind up digoxin to help prevent a lot of cardiac effects. Okay, so I'm going to cut it there. Any questions? Okay, so yes, ma'am. Hypercalcemia can worsen that, so it can just exacerbate some of the arrhythmias you can see with it. So we'll talk about that in the antiarrhythmic section. Hey, just real quick, I will not be here the rest of the week. I'll be at PAEA, so if you have any questions, email me. The next EpiBio is in person, and that's going to be, I think, Monday or Tuesday? Monday? All right, look at your schedule. It's Monday or Tuesday. We're going to do a little journal club session, so I'll post those up with instructions. But please watch some videos before you come into class. It'll help you with evaluating the literature, because you're going to be in a more active position at this next time. So get ready. All right.